So for this presentation, I'm going to be talking to you about the contingency or 2x2 table, and I'm also going to talk a little bit later in the talk about types of error. I do not have any relationship which, in the context of this presentation, could be perceived as a real or apparent conflict of interest. So when we think about diagnostic test accuracy, in general, we were talking about dichotomizing a result, so disease present, disease absent, PE present, PE absent, renal metastasis present or absent. And then we think about the test, and the test can be either positive or negative. So if we think about this, we can construct a table which has the columns with the disease present or absent, and then we can construct rows with the test outcome positive or negative. So that gives us 4 bins in which we can enter this data. So if we look at the first box here, the first bin, which is the upper left box shaded in grey, I'm going to ask you the question. This bin will contain patients who have the disease who test positive for the disease. So the first question is are these the true positives, the true negatives, the false positives, or the false negatives? And the answer to this question is these are the true positives. So these are patients with the disease who test positive for the disease. If we now look at the bin in the lower right hand, again shaded in grey, these are patients who do not have the disease, and when you test them, they test negative. So are these true negatives, false positives, or false negatives? And these are the true negatives. These are the patients who do not have disease, and when you test them, they test negative. So now looking at the bin in the upper right hand, these are patients who do not have the disease, but when you test them with your test, the test comes back as positive. So are these false positives or are these false negatives? And the answer to this question is these are the false positives. So they are false positives because they test positive, but they do not have the disease. And then last but not least, these patients are going to be the false negatives. So the false negatives are those patients that truly have the disease, but they test negative for the disease. So this is the way that we construct the 2x2 table, filling in the true positives, false negatives, and true negatives. Now the next thing to do with our 2x2 table is to calculate a variety of diagnostic test accuracy measures. And these would include sensitivity, specificity, positive and negative predictive value. So if we look at the blue box, which is in the leftward column, we want to figure it out. Is this going to, when we fill this in, are we filling in for sensitivity, specificity, or positive or negative predictive value? And what this value is going to be is the true positives over the true positives plus the false negatives, i.e. the percentage of patients or the proportion of patients who test positive out of all of those with the disease. And the answer here is this gives us sensitivity. So remember, the sensitivity is a statistical measure of how well a diagnostic test correctly identifies a disease. Sensitivity is the proportion of true positives of all those with the disease in the population. And it's calculated by dividing the true positives by the true positives plus the false negatives. So the next thing we're going to calculate is the blue box at the bottom of the right column. And what we want to know is this going to be our specificity, positive predictive value, or negative predictive value? And what this number is going to be, or this calculation is going to be, is the true negatives divided by the true negatives plus the false positives, i.e. the percentage or the proportion of patients that test negative for the disease out of all of those that do not have the disease. And this gives us specificity. So remember what specificity is. It's a statistical measure of how well a test correctly identifies the negative cases out of all of those that don't have the disease. It is the proportion of true negatives in all of the negative cases. And it's calculated by dividing your true negatives by your false positives plus the true negatives. So now we're going to calculate a couple of other statistics, and these are going to be the predictive values, positive and negative predictive values. So if we look at the box that's kind of shaded in the purple color, the question will be, is this going to be our true positives or our true negatives? And this is going to be calculated by dividing the true positives by the true positives plus the false negatives. Another way to look at this is it's going to look at all the patients who tested positive for the disease, what proportion of them actually had the disease. And this is your positive predictive value. So the positive predictive value is the proportion of patients with a positive test who are correctly diagnosed. It reflects the probability that a positive test reflects the underlying condition, and it is calculated by dividing the true positives by the true positives plus the false positives. And then last but not least, we're going to calculate the other statistic in the purple box, and by a process of elimination, this has to be the negative predictive value. So the negative predictive value is the number of patients who do not have the disease out of all of those that test negative for the disease. So as I said, it's the proportion of those with a negative test who are correctly diagnosed, and it is calculated by dividing the true negatives by the true negatives plus the false negatives. So we're going to ask a couple of other questions now related to some of the topics we've talked about, including sensitivity and specificity. So question number 9 asks, if you had a diagnostic test that had a sensitivity of 85% and a specificity of 95%, is this test reliable for ruling out the disease in question, reliable for ruling in the disease in question, reliable for both, or reliable for neither? So when we say a diagnostic test has high specificity, I should specify that in general we're talking about 95%. And if you find that you have a test that has a high specificity but is positive, then that test essentially rules in the disease. So remember, high specificity test is a test that's good at identifying those that don't have the disease. So it's good at identifying the true negatives. If the test tests positive then, and it has a specificity of 95% or higher, then you can rule in the disease. And this is called a spin test, with the SP standing for specificity, the P for positive test, and then you can rule in the disease. So this is a spin test. Now, if you have a spin test, the other test that you can have is a snout test. So the snout test, again, is a diagnostic test that has a high sensitivity, again, 95% or higher. This test is good at identifying those who truly have disease. So when this test is negative, again, it can be believed, and it's essentially a test that's good at ruling out the disease in question. So again, a snout test with the SN standing for high sensitivity, N for negative, and ruling out the disease. So that's what a spin and a snout test is. So it tells you whether a test is good at ruling in or ruling out the disease if sensitivity or specificity is 95% or higher. So the answer to question number 9 is it's reliable for ruling in the disease because specificity is 95%, so it is a spin test. Okay, so I'm going to ask you another question. So question number 10 is, again, we have a 2x2 table. We have disease positive, disease negative, and people testing positive or negative. So in this particular question, is this test reliable for ruling in the disease? Is it reliable for ruling out the disease? Is it reliable for both, or is it reliable for neither? So this will require you calculating what the specificity and what the sensitivity for this test is. So the specificity is going to be 42 divided by 42 plus 8, or 42 divided by 50, which comes out at 84%. And then the specificity is going to be 48 divided by 48 plus 2, or 48 divided by 50, i.e. 96%. So this particular test has a sensitivity of 84% and a specificity of 96%. So it's a high specificity test. It's 95% or higher. So therefore, this test is a good test at ruling in the disease. It is a spin study. It's high specificity. If the test is negative, if the test is positive, you can rule in the disease. Okay, so moving on to the next question, we have a diagnostic test which has a positive predictive value of 95% and a negative predictive value of 85%. Is this test equally good at ruling in and ruling out disease? Is it better at ruling in than ruling out? Is it better at ruling out than ruling in? Or you can't tell from the available data? So the answer to this particular question is that you can tell from the available data. And the reason for this is you have to remember that positive and negative predictive values depend on disease prevalence. The positive predictive value is the proportion with a positive test who have the disease. The negative predictive value is the proportion of the population with a negative test who do not have the disease. But as I said, this will depend on disease prevalence, unlike sensitivity and specificity. So you do have to correct your positive and negative predictive values depending on what the prevalence of disease is. And this will vary. So in a tertiary academic center, often you have high prevalence of disease. In a community hospital, you may have a much lower prevalence of disease, and you have to make corrections for those changes in prevalence. So as I've said, you have to look at the prevalence reported in the literature and see if they are representative of your local prevalences. And they may not be, and you may have to compensate for that. So moving on to question 12. An audit shows that you have a diagnostic accuracy of 98% when reporting preoperative chest radiographs. Which of the following statements are true? So number one, your skill level is adequate, you're good at what you do, you're appropriately trained, or you cannot make a meaning inference from this data. So before we answer that question, let's just think about what accuracy is. So diagnostic accuracy is the proportion of patients who are correctly diagnosed divided by all of the patients. So essentially, it's your true positives plus the true negatives, because they're the proportion of patients who are correctly diagnosed divided by your true positives plus your true negatives plus your false positive plus your false negatives. Now, something that you have to bear in mind is, if I was reporting these chest x-rays and, for instance, say I never looked at any of them and said that they were all negative, and only 2% of the chest radiographs actually had an abnormality, I would still have an accuracy of 98%. Of course, my specificity would be 100% because I would identify all of the negative radiographs, but I would have a sensitivity of 0 because I would identify none of the positive radiographs. So when interpreting accuracy, you have to do it in the setting of sensitivity and specificity. You cannot rely on accuracy alone. Now, moving on from sensitivity and specificity and positive and negative predictive values, they are measures of really the test. When it comes to clinical medicine, often what the clinician really wants to know is, how has performing the test changed the pretest probability before the test to the post-test probability after the test? How has it changed what the likelihood of disease is? And that information is something that the clinician requires to inform their decision-making. Will they administer treatment? Will they withhold treatment? What is the probability that the disease is present? So likelihood ratios are generated by combining sensitivity and specificity data. A likelihood ratio, for a negative test lies between 0 and 1, and a likelihood ratio for a positive test ranges between 1 and infinity. A positive likelihood ratio tells you how much the odds of the disease increase when the test is positive. It is calculated by dividing sensitivity by 1 minus specificity. Or another way to look at that is, it's calculated by dividing your true positive rate by your false positive rate. The negative likelihood ratio tells you how much the odds of disease decrease when a test is negative. It is calculated as 1 minus sensitivity divided by specificity, or your false negative rate divided by your true negative rate. The closer the likelihood ratio is to 0, the stronger the negative test is, and the better it is at excluding disease. And conversely, the higher the likelihood ratio is, the stronger the positive test is, and the more likely the disease is to be present. If you have a likelihood ratio of 1, essentially that test is useless because it doesn't change the pretest probability to a different post-test probability. So in general, numbers that we use for likelihood ratios are, if a test has a likelihood ratio greater than 10 or less than 0.1, that is considered a large change in the likelihood ratio. If a test has a likelihood ratio between 5 and 10 or between 0.1 and 0.2 for a negative test, that's considered a moderate change. And then tests with a likelihood ratio of 2 to 5 for a positive test or 0.2 to 0.5 for a negative test are considered small changes. And as I said, a likelihood ratio of 1 equals no change. So a way to interpret this is to use a variety of things, one of which is a thing called the Fagan nomogram. So we can see at the Fagan nomogram, what we have here is a list of pre-test probabilities. Prior to testing, this can be considered to be the prevalence of disease. So a patient comes in, you don't know if they have a disease or not, the prevalence is in this population, so that's what you have. When you do the test and you work out what the positive or negative likelihood ratio for that test is, that then is used to calculate your post-test probability. And I'll show you an example here. If we had a positive test, imagine we had a patient that came in, you didn't know whether they have disease or not, and let's just pick that the pretest probability is 0.5 or 50%, so you could flip a coin to figure out whether they have the disease or not. We perform a test which has a positive likelihood ratio of 10. So if you draw a line from 0.5 as your pretest probability going through a likelihood ratio of 10 and see where this intersects your post-test probability, you are intersecting at 0.9 and 90%. So you've gone from having a probability of disease that's about 50% prior to testing to now 90% after the test has been performed. And depending obviously on what the disease is, that may influence a clinician to decide whether to administer a therapy or withhold a therapy. Obviously, if the test is negative, the way we would interpret this is, again, pretest probability is 50%. Let's imagine the likelihood ratio is 0.1. And we can see this reduces the post-test probability to about 10%. So the patient has gone from having about a 50% chance of having this disease prior to testing to a 10% chance of having the disease after testing. And again, this will influence or inform the clinician about decision-making about whether you administer or withhold therapy. Another way to do this is to use a graph of conditional probability. And this here is an example of a graph of conditional probability for a weak diagnostic test, so a test with a sensitivity of 65% and a specificity of 65%. Again, if we take the patient who has a pretest probability of 50%, so again, you could flip a coin to see whether they have the disease or not, we administer a test, and then what you do is you see where this intersects with this dark blue curve, and then go across here to see what the post-test probability is, and we can see that this is about maybe 62, 63%. So the patient goes from having a probability of disease of 50% prior to testing to 63% after testing. So this hasn't really moved the probability of disease that much. Similarly, if the test came back as being negative, we would go across here. We'd see where this intersects with the pink line, go across here, and we find out that the probability of disease is maybe 37, 38%. So again, hasn't moved your post-test probability that much compared to the pre-test probability. Now, if we look at a test that is a strong diagnostic test with sensitivity of 95% and specificity of 95%, so as I said, a spin and a snout study, again, we take the patient with a pretest probability of 50%, we administer a test, the test comes back as positive, and if we go over here to see what our new post-test probability is, this is probably at around 97%. So again, the patient came in with about a 50% chance of disease prior to testing. We perform a diagnostic imaging test, the test is positive. Now the chances of disease are about 97%. So this will probably change the clinician's decision making, and they will probably administer therapy based on that information. Similarly, if the test was negative, we see where it intersects with the pink line, go across here, and again, 2 or 3% chance of having disease in the presence of a negative test. The clinician's most likely going to withhold therapy. So you can see how this information alters physician decision making and informs what the post-test probability is after the test has been performed. I'm going to talk a little bit now about types of error. So I just want to recap what the various error types are. So remember that a type 1 error is the probability of rejecting a null hypothesis if the null hypothesis is actually true. So we're saying the null hypothesis, we have two groups, we're saying there's no difference between them, but what happens is you reject the null hypothesis and you think there is a difference even when the difference is not present. And the type 1 error rate is related to your p-value. So another way to look at this is, if you're doing a statistical analysis, a way of minimizing your type 1 error is not to perform too many studies. So if you performed 100 tests on these groups of patients, and you set your p-value at 0.05, 5 tests will come back as, or there's the potential for 5 tests to be positive just by random chance rather than them being truly positive. Or even if you did 20 tests, you might expect one of them to be positive by random chance rather than it be truly positive. Your type 2 error is the probability of failing to reject the null hypothesis even if the alternative hypothesis is true. So it's not identifying a difference between the groups even though a difference is present. Power is the probability of rejecting the null hypothesis if the alternative hypothesis is actually true. And power is related to your type 2 error in the equation that power is equal to 1 minus your type 2 error. Researchers calculate sample size to minimize your type 1 error and to maximize your power. By maximizing your power, you're going to minimize your type 2 error as well. So just think about this, this issue here to kind of illustrate what I've just talked about. And remember, when samples are extremely large, maybe in the order of tens of thousands, nearly all statistical tests will have close to a 100% power to reject a null hypothesis. So even if there's a small amount of evidence in favor of the alternative hypothesis, an example would be in, for instance, beta blocker medications. If you had a trial comparing a beta blocker A to beta blocker B, or beta blocker A to placebo, and there was a very small reduction in blood pressure, 2 millimeters of mercury, 5 millimeters of mercury. If you powered this with thousands or tens of thousands of patients, it will be possible to identify very small changes as being statistically significant, but these changes may not be clinically meaningful. So that's just something that you have to bear in mind. I'll give an example here of a university with a 50-50 breakdown of males and females. Researcher draws a sample of 30,000 people. The proportion of males is estimated to be 50.1%. The proportion of females is estimated to be 49.9%. When they perform a statistical test, this is highly significant with a p-value of 0.0001, and the researcher rejects the null hypothesis and concludes that the university discriminates against females. But we have to realize that that doesn't really make sense. So again, it's just another way of illustrating the point that things have to, as well as be statistically significant, they also have to have meaning as well. So remember, the researcher needs to make a distinction between what's statistically significant, p-values, type 1 error, power, etc., and practical or clinical significance. I thank you very much for your attention.